दिसलं सर, स्क्रीन दिसतंय.
स्क्रीन दिसतंय ना? ठीक आहे, ठीक आहे. बरीच मंडळी गोळा झालेली दिसतात तिथं. सगळ्यांना मास्क वगैरे लावून.
I'll just start. First of all, sir, thank you very much for sparing your time in this crisis period.
Thank you,
We are
sir. Thank you.
all eager to participate in the seminar. So Dr. Jani has taken out time. He is right now in his office and given his time for this slide seminar. So these are all our PG students, first year and second year.
Nice, nice.
Congress sir is there, Dr. Angarkar sir is there, Bhavesh madam is there, and few of our lecturers are there.
Very nice, very nice. बरीच लोक आहेत. सगळे होपफुली एव्हरीबडी इज डुईंग फाईन. आणि हे कोविडमुळे सगळ्यांनाच खूप त्रास असेल तिथं. तुमच्याकडे खूप पेशंट आहेत का सर तुमच्या इथं?
बऱ्यापैकी वाढले सध्या.
हो ना. So breast pathology is less important than COVID now, but and maybe one day we'll talk about the COVID pathology. It's an infectious disease. So there are some people who have done a lot of autopsies in the COVID cases, and maybe one day we will take that topic as a point of discussion. Can you all hear me? If you can hear, just raise your hand so that I can know everybody can hear me. Yes, I can see everybody also nicely. So what I thought is that we have about 45 minutes for today's presentation. So I initially wanted to try with a different software, but
सर मला मी थोडं इंटरप्ट करतो.
काय म्हटले सर?
थोडंसं इंटरप्ट करतो.
सर आवाज येत नाही सर क्लिअर तुमचा.
लिंक आहे ना ती लिंक आताची जी झूमची लिंक आहे.
हा 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 हा.
ती मला पाठवली का सर ravindra.karlela?
नाही पाठवली सर. मी आता हे पाठवली तुम्हाला ते रुरल मेडिकल कॉलेजचं जे होतं ना ऍडमिट ईमेल त्याच्यावरती पाठवले.
बरं. नाही कारण आपले काही फॅकल्टी बाहेर पण आहेत. म्हणजे
एक मिनिट मी तुम्हाला पाठवतो परत एकदा इन्व्हिटेशन पाठवतो.
ravindra.karlela म्हणजे आय कॅन शेअर दॅट विथ देम.
हो एक मिनिट. हा जीमेल सर पाठवून दिलाय. So hope everybody is able to see this presentation. You are able to hear me, and while presenting this point, if you have any questions, just raise your hand so I can see you here on my screen. So I will stop my presentation and we can talk about the questions you have. Not necessary we will be able to finish all the slides or all the cases which I have taken for today's discussion. We'll go for 45 minutes. So anything remaining will continue next time when we meet. This will be like ongoing series of discussions, and we'll try to be as interactive as possible. So it will not be like in a conference meeting or somewhere we have like a presenter comes and presents and then he goes away. 1 second. Sorry, somebody was here at my office, so somebody knocking the door. So this might happen in between, so I had to pause in between. So my point is that this will be like an ongoing series of presentations. So we will try to be as much interactive as possible, and you can ask all the questions, and we'll try to share as much knowledge as possible. So this is the first case, 46-year-old woman who presented with right breast nodule, and this nodule was noted on the screening mammogram. Now this patient reported bilateral milky discharge coming from both the nipples over the period of past 5 years, but then over in last 6 months, she noticed like discharge becoming brownish in color, which means there was some sort of a blood also mixed with the discharge. And she does not have any family history of breast cancer, and the patient has no prior breast biopsies done. So ultrasound revealed about 15 millimeter solid circumscribed ovoid hypoechoic nodule at 4 o'clock position, right breast, and the lesion was biopsied under ultrasound using 14 gauge needle, and 6 passes were performed. This is a digital slide of that case, and you can see that there are multiple cores. All of you are used to digital slides now. Is that yes or no? Yeah. All of you are looking at the digital slides in your lab? Yes, yes, yeah. So that's good. So this is a digital slide of the case, and you can see there are multiple cores here. And at this low power, you can see that it's a lot of blue color. In the pathology, blue is bad. So we can start seeing a lot of cellularity, and then there are some pink areas here. So then when we go high power, you can see small openings, some sort of a papillary structure. Can you see my arrow or cursor? Are you able to see my cursor? Yeah? Okay. So maybe I can use this here. You can see this. There are a lot of papillary structures here. So more papillary structure here, like that. So a lot of papillary architecture here. And then if you go around, you can see some dilated spaces, but some glandular or ductal architecture. And here you can see more of those fragments with the papillary architecture here. So looks like some sort of a papillary lesion. And then we go high power. Is the resolution of the picture clear at your end, or? Yeah. So we go still high power, and you can see that there are blood vessels here, some capillaries here, and now the prominent fibrovascular core. But now I'll zoom in, and you can see that there is one layer and then another layer of epithelium, right? So 1 and 2 layered epithelium. If you move around, you'll be able to see more 1 and 2 double layered lining epitheliums here. And almost all the nuclei, they look like monotonous actually, right? Everything is looking monotonous here. More fibrovascular cores and myepithelial cells and epithelial cells. So there are two layered linings. We go to other fragments, again showing the similar structure. Some hyperplasia here forming the cribriform pattern. But again, the nuclei almost are looking identical to each other. So we go here. There's some apocrine change here, some apocrine metaplasia here with dilated ducts. Right? So we'll move around a little bit more. So browsing a digital slide is different than browsing a HPE slide on the microscope because To me, browsing on the on the on the computer, you might miss a couple of fragments. So we'd be really careful to see all the fragments actually. There might be a benign lesion in one of the fragment, and there might be another atypical lesion in the other fragment. So it's very important to look at all the fragments. Sometimes we jump to the diagnosis just by looking at one of the fragments, but we have to be careful. Make sure we look at each and every fragment. Here you can see that there's a procrine metaplasia here and some cribriform architecture. So any guess? Anybody wants to say something about this case? I can't hear. Only thing about the interactivity here is that I can't hear your sound clearly because you might be sitting away from the microphone, but that maybe we can appoint one person as a leader who can sit near the microphone. So he or she can be just right next to the microphone. So then that person can convey all the messages of so then I can hear that person clearly. Yeah, just take a chair and sit next to the microphone. Yeah, that's good. That's good. Thank you.
That papilloma with apocrine metaplasia.
Yeah, yeah. So go ahead. I can hear you.
Usual ductal hyperplasia, epithelial hyperplasia.
Yeah. So maybe next time when we meet, maybe one of you can have a headphone or something so your sound becomes clear. But anyway, so this is definitely a benign lesion. And how do we confirm this benign nature of this lesion? What immunohistochemistry would you like to do on this case?
CD P63 for the basal cell.
Yeah.
And
What?
So P63 for nuclear staining.
Yeah.
Myoepithelial cells to highlight the myoepithelial cells. And marker. Again for myoepithelial, highlighting the myoepithelial cells.
Yes. Yes. Wonderful. So yes, we have to highlight now to prove that this is a benign or pre-neoplastic or neoplastic, papillary lesion. We have to do a myoepithelial cell staining. So as rightly said, P63 is one of the stain which we use to highlight nuclei of myoepithelial cells. I usually prefer using a muscle-specific myosin or smooth muscle myosin stain, which highlights the myoepithelial cells very nicely. And if you have facility and you can afford, you can do two stains sometimes. So now, sometimes, okay, this is a different thing. Let me see. I can, okay. Okay, here it is. So again, this is the picture photomicrograph. Is it clear or it's not clear? Again, having some different case, but then core biopsy is showing this papillary architecture here. And high power of the same case, having dilated duct filled with this papillary projections and some sort of a cribriform pattern here. That's the high power picture of the same. A benign looking, monotonous looking nuclei. And again, we have to do the stain to highlight the myoepithelial cells. So here, smooth muscle myosin and another stain which I use is CK56, cytokeratin 5 and 6. This is a high molecular weight cytokeratin which highlights the myoepithelial cells very nicely. And here you can see that we can see the nice staining of all the myoepithelial cells. So So the core needle biopsy diagnosis is intraductal papilloma. So what would you recommend? I usually don't recommend, but if somebody asks you that what should be the treatment in this case, so what would you say? Say in the examination you have a question that what is the management of the intraductal papilloma? So what is the answer?
Surgical excision.
Surgical excision? Yes. So why? It's a benign lesion. So why do you want it to be excised completely?
Has a discharge, and like if she has repeated discharge history, then it can convert to malignant.
Symptomatic
Later.
relief for patient. For symptomatic relief to the patient.
Okay. So your answers are correct, but that will not give you passing marks in the examination, because what examiner is looking for is that all the papillary lesions of the breast has to be completely excised. Why? The answer is that even though in the core needle biopsy it may show intraductal papilloma, papillary lesions can be associated with in situ or invasive carcinoma, very high prevalence. So all the papillary lesions has to be completely excised. Even in the fine needle aspiration cytology, you might find papillary lesion and you may be able to diagnose it as a benign lesion. Still, um, we need to excise all the papillary lesions. Okay, don't keep any papillary lesions inside. So this patient underwent excision, and the excision was a needle localization lumpectomy. Do you know what is a needle localization lumpectomy? Have you seen a case? Do you get the specimens of needle localization lumpectomy in your institute?
No,
No,
sir.
sir.
Do you know what it is?
No, sir.
Okay. So needle localization lumpectomy is breast conservative surgery in which under the mm, under the radiological guidance, maybe mammogram most of the time, or ultrasound sometimes, they put a needle in the breast at the site of the lesion. Now, there are statistical data which shows that even if the breast cancer treated with complete mastectomy, total mastectomy, or modified radical mastectomy, or breast conservative surgery, which is lumpectomy with the needle localization. Needle is used to identify the site of the lesion. So they put a needle under the ultrasound guidance at the site of the lesion, and then the surgeon will go for the surgery and excise the area surrounding the lesion. So usually the lesions are smaller in size, like say 1 centimeter or less. Then they put a needle localization, so they don't miss the lesion. So before the surgery, like say 1 hour before the surgery, patient will be examined by the radiologist. Radiologist will put a needle, and then the surgeon will take the patient to the OR, excise the lesion with the needle, and specimen is sent to pathology with the needle. So what I usually do is that when I get a needle localization lumpectomy specimen, I will usually surgeon orients the specimen with short sutures superior and long suture lateral. Do you get oriented specimens in your lab?
Yes, sir.
Yeah. Then how do you gross a breast? Say mastectomy specimen came to your lab with the orientation. So what do you do next?
First step is to ink the specimen, like ink the base.
Yes. And then
We'll take all the dimension of the specimen, including the overlying skin, the whole specimen, and we will palpate for the lung. After examination, the nipple areola, the skin, any pudiorin change or anything, nipple retraction is there or anything. Then we mention means the needles and whatever the orientation is given, we'll mention in our record. so that it will be further like if it is needed, we can go back and see. And then we'll do serial section from the base after inking. Before that, we'll palpate the lump. We are getting any lump where it is, and we'll see the previous FNAC or biopsy, whatever they have mentioned on the form, where they are localizing the lesion, what they have mentioned in their form, and then we'll palpate the lump if we are getting the same thing in our specimen, and then we'll do serial section with 1 centimeter distance, and then we'll fix the specimen. And before that fixing, we'll see if we can measure the lump size, tumor
Mm-hmm.
size. And then we'll fix the specimen with formalin, and we'll putting the formalin soak cotton in between. And then next day we will take after 12 hours fixing, we will take it for crossing next day.
Mm-hmm.
And
Mm-hmm.
then if they are sending it separately, the lymph node or axillary test, that also we have to mention. And then next day we'll measure the lump size. We'll see how much it is from like closest base, from closest lymph, from superior soft tissue margin, from skin margin. It is going into the nipple areola complex, or how much distance from where it is. And then we'll separate out the adipose tissue, which is sent as an axillary fat if it is attached with our specimen, or if it is sent separately. And then we'll take the sections.
Very nice. So how many sections you take from the breast lesion, and how many sections from the other parts of the breast? How do you do it?
If it is unifocal tumor, we'll take minimum 4 sections from the tumor proper. Then one with the closest base. Then with the if we are getting it with close to the nipple areola, or nipple areola will be sent separately. And then with the adjacent parenchyma, and then we dissect for lymph nodes.
Tumor with adjacent normal breast section.
And normal adjacent breast also will take.
Yeah, so very nice. Very nice protocol for the breast grossing. So usually take sections from the lesion. If it is less than 2 centimeters, submit the entire lesion in toto. And then take the sections from all the 4 quadrants of the breast. So 2 sections from each quadrant. So total 4 quadrants. We take 2 sections from each, which might be normal looking. You take the sections from them and then completely submit nipple and areola, and then submit the lymph nodes. Now, fixation is very important in the breast pathology. Why fixation is very important?
Sir, I want to ask something.
Yeah, go ahead.
So why section is important from the normal breast?
I'm sorry, I can't hear you.
Why section is important from the normal breast? Like why we
Oh,
are
why sections from the normal breast? Yes, so sometimes the lesions are multifocal. We may be missing the ductal carcinoma in situ. One of the parameter in synoptic reporting of the breast cancer is the extensive DCIS. So we want to identify all the DCIS within the breast and any other associated incidental multifocal tumor. We will like to submit that also. So extensive sampling of the breast is very important. Now I was asking about fixation in the breast. This is very, very important point in the breast pathology is the fixation. So minimum amount of fixation required is 24 and maximum is 72 hours. So your fixation cannot be more than 72 or less than 24. And why is that so? Can somebody help me there?
Yeah.
So the code is timing. So for I'm not sure, sir, but like for ERPR-HER2 IHC, it will matter for the like positivity of the markers.
Mm-hmm. Yes.
Again, cold ischemia timing also matters, like from where we are taking out the specimen and keeping it in formalin.
Mm-hmm. Mm-hmm. Absolutely, absolutely. So it is required for ERPR and HER2/neu. Hormone receptor status fixation is very important parameter because if it is less than 24-hour fixation, then the antigen retrieval process will not be accurate, and hence your results may not be ERPR HER2/neu interpretation results will not be accurate, and hence it is very, very important. I'm receiving a telephone call. I'm just going to mute for 1 second. Sorry. So for hormone receptor status, the formalin fixation is very, very important. Now, sometimes I see that when say on the Friday surgery is done and then everybody is off on the weekend, Saturday, Sundays, nobody's in the lab, and the specimen is sitting in the lab for like 2 days without anybody opening the specimen. That is not good. Breast case, in fact, for any cancer, but especially for breast cancer, we have to section the specimen within half an hour of surgery. And why is that so? Does anybody knows why should we gross the breast specimen as soon as it is received in the lab?
Sir, ischemia timing, does it matters for it?
Why the timing is important?
So again for ERPR HER2, it will change.
Well, ERPR HER2/neu, and another thing is that there is a we grade the breast cancer using modified Bloom-Richardson grading, BMR. Do you know Bloom-Richardson grading?
Tubule formation.
ERG. Modified Bloom-Richardson grading. So in that, one of the parameter is the mitotic activity. So architectural index, the nuclear index, and the mitotic activity index. So what happens is that once the specimen is removed from the patient's body and it is sent to the laboratory, after half an hour, mitotic index decreases actually. So then your modified Bloom-Richardson grading will not be accurate. So we have to section the breast as soon as it is received in the lab, section it at equidistance of 5 millimeters, and then fix it in formalin for 24 hours and come back and gross next day. So then we submit the section. Similarly is for the breast needle localization lumpectomy. Breast needle localization lumpectomy also has to be sectioned immediately within half an hour of surgery because again, as you rightly said, fixation affects the ERPR HER2/neu and also our modified Bloom-Richardson index. Breast cancer grading is also different if our fixation is not proper. So we fix it over the period of 24 hours and then come back next day and start grossing it. But we should not overfix also. So more than 72 hours fixation also affects the antigenicity of the tumor cells, hence we should not overfix. So this patient underwent needle localization lumpectomy 2 months after because all the papillary lesions of the breast has to be completely excised. And the patient underwent needle localization lumpectomy, which is a breast conservative surgery. And what did we find in the breast? So here is one of the sections. You can see the ink all over, right? Here. And then here you can see that there's a lesion here, which is a papillary lesion. And I'm zooming in on high power also. And you can see that it has this cribriform architecture. And yeah, you can see the myoepithelial cells here and the ductal epithelial cells here, and then apical snout and secretions here. You can see some secretions coming here.
Lactating state.
Yeah.
So that apicus snouting indicate lactating means active glands.
Yeah. Here you can see the myepithelial cells and the epithelial cells.
तर याच्यात myoepithelial cells एकदा दाखवा सर परत.
Sorry, sir, I can't hear you.
Sir, can you show the myoepithelial cells again?
Yeah, 1 second. I'll go back there. I want to show you this area. You see this area?
Yes, sir.
This is the area where here you can see that this is a little enlarged nuclei, and there is this fibrovascular core here, but here we don't see the myoepithelial cells in this area,
Yes, sir.
right? And it has like a there are myoepithelial cells here in this and the epithelial cells, but here you can see the single layered lining in this area. So there is a mix here. There's an intraductal papilloma. Here you can see epithelial and myoepithelial cells, myoepithelial and epithelial cells here. Can you all perceive that? 1 and 2. Can you all appreciate it?
Yes, sir.
There's myoepithelial and epithelial, but here you can see only one layered epithelium. So this is a case of ductal carcinoma in situ arising in a case with intraductal papilloma. So there is intraductal papilloma here with the apocrine apical snout and secretions and some hyperplasia, but here is the ductal carcinoma in situ here. So ductal carcinoma in situ is known to be associated with intraductal papillomas, and this is a picture where there's a ductal carcinoma in situ in an intraductal papilloma here, right? Now there you can see focal area of necrosis as well. So I just wanted to introduce you some of the papillary lesions of the breast, and they're not very common, but we do see quite often in our practice. About 5% of the times we can see on the breast core-needle biopsy papillary lesions of the breast. And this case was intraductal papilloma with ductal carcinoma in situ. So the biopsy was intraductal papilloma, but when the excision was done, there was a DCIS along with it, and the margins were clear. So whenever we excise or take section of breast lumpectomy or mastectomy, it is very important to take all the sections from the margins. So I usually paint the margins with 4 different colors, like I paint superior with red color, inferior with blue color, anterior with green, posterior with black, like that. So you can use different colors to highlight the margins, but margins are very important in this case. So the case was signed out as intraductal papilloma with DCIS, margins negative. And then, classifications of papillary lesions of the breast can be benign lesions, atypical lesions, and malignant lesions or the papillary lesions. So benign papillary lesions are like solid intraductal papilloma, multiple solitary intraductal papilloma, multiple intraductal papillomas, and papilloma with usual ductal epithelial hyperplasia. Some papillomas are associated with atypia, so atypical ductal epithelial hyperplasia. So it's same as ADH in the breast case. So it's papilloma with ADH, and then malignant papillary lesions are like a ductal carcinoma in situ within the papilloma itself. So like our case. But some cases there is a complete papillary lesion is neoplastic. So it's called papillary DCIS, where there is no papilloma, entire lesion is neoplastic. So it's called papillary DCIS. And then there is intracystic papillary carcinoma. So, and then there is a subtype which is there is invasive carcinoma arising in intracystic papillary carcinoma. There is another subtype which is called solid papillary carcinoma, and then invasive papillary carcinoma. So over the period of coming few sessions, we'll talk about this one at a time. We'll try to cover as much as possible today, and then we'll meet again next time and we'll cover those topics as well. So papillomas, they can be central or they can be peripheral. Central means just underneath the nipple areola region, and peripheral means in all the 4 quadrants of the breast. Now, central papillomas usually tend to be solitary. Solitary means single, 1 in number. So there is only one papilloma. But then peripheral papillomas can be numerous, more than one. So there are multiple papillomas arising in terminal duct lobular unit. So that's called multiple papillomas. Now, central papilloma, they can present as a palpable mass, or they can present as a radiologic abnormality like opacity or microcalcification under the mammogram. And then, as in our case, there was a nipple discharge. So papillomas usually, when they undergo bleeding, usually because of the torsion of the twisting of the stalk of the papilla, fibrovascular core of the papilla, and that is when it starts bleeding, and then the bleeding become so the nipple discharge initially is milky, but then when there is a bleeding, then it becomes brownish in color. So here is a case. You can see that there is a nipple and a discharge coming out, and this is a central papilloma, single papilloma. Usually single unilateral, arising from the single duct, and they spontaneously present, they persistent to discharge, and it can be, as I said, it can be bloody or it can be clear also. That was central papilloma, and then peripheral papillomas, they present most of the time as mass lesion, palpable mass lesion, and a mammogram, if you do, you might find a mass lesion, you might find asymmetry, you might find calcifications. Ultrasound finding will show normal in up to 20%. Sometimes it can show as a cystic lesion, complex cyst, or it can present as a solid mass lesion. So that's the peripheral papillomas. So here is another case representation of a papillary lesion. The dilated duct here, you can see that nicely, and it is filled with this papillary lesion here, right? And there's a myoactin stain here, which highlights the myoepithelial cells. This is a case where you can see there is a lesion here, which we excise and see under the microscope. It looks like a dilated duct, which is filled with a cystic papillary lesion. This is a high power view of the same lesion, and you can see that the benign looking epithelial cells, if you look carefully, there might be double layered epithelium. You may be able to see it. Again, another view of a similar lesion, and a dilated duct filled with a papillary lesion here, and you can see that epithelial cells, and then the myoepithelial cells here. Yeah. Any questions you have as of now? No questions.
Do we need to mention the grade of DCIS if we are getting as an incidental finding in papilloma?
Yes, yes. So anytime you see a DCIS, you mention 3 things in the DCIS reporting. First is the architecture of the DCIS, whether it is solid, cribriform, papillary, Then second is the nuclear grade of DCIS, grade 1, 2, 3. And third is the necrosis in the DCIS, whether you see necrosis or not. Now, if it is a excision specimen, then you report the extent of DCIS. More than 25% of the lesion or specimen, if it shows DCIS, then you call extensive DCIS. And then margins for the DCIS. So you report the margins if it is a lumpectomy or excision specimen. Very good question. Anybody else have any question? No? Very good.
IHC for DCIS. Sir, any IHC like for DCIS there?
IHC for DCIS, you mean to say, or?
Yes, sir.
Yeah, so we do myosin stain again to rule out invasion. And if you do cytokeratin 5 and 6, the myoepithelial cells in the, there is a slide actually coming next, but I will just highlight here, is that if you want to separate or distinguish usual ductal epithelial hyperplasia from ADH or DCIS, then you do myoepithelial cell staining CK56, high molecular weight keratin. And CK56 is usually absent in the areas of DCIS, while it will be present or it will be staining nicely in the areas of usual ductal epithelial hyperplasia. And ADH also will be negative with the CK56. However, there is only one caveat here, is that if it is a DCIS, which is a basal type DCIS, which means DCIS arising from the basal cells, then it will be staining with CK56. But that's a very rare scenario. So most of the time, CK56 can help you to distinguish UDH from ADH and DCIS. And then again, myosin stain to distinguish DCIS from invasive ductal carcinoma. Is that okay?
Yes, sir.
Yeah, is it helping you? Or?
Sir, like in MRM specimen, we are removing the breast. Then why we have to mention the DCIS component if they're getting in the periphery?
Very nice questions. Very nice question. So in the radical mastectomy case, I'm just lowering my desk. In the radical mastectomy case, we always mentioned extensive DCIS because the DCIS can be bilateral also. And if it is extensive DCIS, then the patient has to be monitored for the disease on the other side of the breast also. So.
That's all. Thank you, sir.
Okay. So as I said, there is another category of the papillary lesion, which is atypical papillary lesions or papilloma with atypia. And I was mentioning about cytokeratin 5-6. So do you see this is the stain here? And if you see, this is the papillary lesion here on the breast. And here in between, there's a cribriform cookie cutter appearance with the bridges having this cribriform architecture. Looks like DCIS or ADH, but how do you prove it? So you do the CK56. And if you see carefully, CK56 is staining those myoepithelial cells here, but in the DCIS area, it's negative. Do you all agree with that?
Yes.
Yes or no?
Yes, sir.
Yeah. So do you have CK56 in your lab?
Yes, sir.
Yeah, you use it quite often or very rarely?
No, sir, we are using it
You're using it in the breast cases?
for prostate.
Prostate, you don't need CK56 actually, but I mean, you can use it. Prostate, we usually you use 34 beta E12, MCAR, and P63. These are the 3 stains for the prostate. For the breast, I usually prefer myosin, smooth muscle myosin heavy chain, and CK56. These are quite specific and sensitive here. But again, the point here is that you can distinguish. Now, this is only duct here, and the size of this is less than 3 millimeter. So I will call it as ADH, right? So you know how to distinguish between ADH and DCIS, right? Everybody knows what is the difference between ADH and DCIS?
No, sir.
No? Yes or no?
Sir.
I can't hear you. Sorry. Can you say that? Yes or no?
No, sir.
No, no. Okay. So what is the difference between ADH and DCIS? So when the size of the lesion is very small, like in this case, this lesion is less than, say, I would say less than 1 millimeter actually. And it is involving less than 2 ducts here, 2 or less than 2 means only 1 duct or very small lesion. Then here we call it as ADH. Even though this is good enough to call DCIS, but the lesion is very small and involving only 1 duct. So I will stop at calling it ADH or atypical papilloma or atypia involving the papilloma. And the same criteria even in the setting of non-papillary lesion. So ADH, there are 2 criteria. One is by a scientist called Page and another is by a scientist called Tavasoli, right? So Tavasoli labels DCIS depending upon the size, while the Page defines depending upon number of ducts involved. But again, when it is a very small lesion involving less than 2 ducts, 2 or less number of ducts, then we call it as ADH. Now, there is another lesion here. You can see that this is a papillary lesion with a fibrovascular core, and then the nuclei are quite atypical actually. If you zoom in, you might start worrying about it. Do you worry about this nuclei?
Which one, sir?
Yeah. Are you able to see the nuclei?
Yes, sir.
Are they worrisome?
Yes, sir.
They look like really bizarre looking nuclei, But then this nuclei are because of apocrine metaplasia. Here you can see this is apocrine metaplasia. And the nuclei in the areas of apocrine metaplasia can be very bad looking actually. And if you just directly zoom at 40x, oh my God, you'll say this is a cancer or ductal carcinoma in situ, but this is not so. We should avoid this look in case of apocrine metaplasia, Apocrine metaplasia can be associated with bizarre looking nuclei, but those are like part of the apocrine change. So we should not be too much worried about those nuclei. Because here you can see that even though the nuclei are bad looking, there's abundant cytoplasm, right? So NC ratio is not very high here in this case. And sometimes you might be able to see some mitotic figures, but still again, apocrine metaplasia can be associated with all those bad features. So not to worry about that. But apocrine metaplasia is commonly associated with papillomas, and that can give a scary look if you zoom in everything at high power. Sometimes we have this tendency to zoom in at high power immediately. But under high power, everything looks bad actually. Have you noticed that? What is your experience? If you zoom in at high power, does it look scary many times?
Yes, sir.
Yeah, because benign looking cells also might look bad. So usually we try to see the slide at the low power, and wherever required, then we zoom in. Otherwise, if you zoom in at the beginning, like say if I zoom in without looking at overall architecture, I might get worried about this. But then I see, oh, papillary architecture, apocrine metaplasia. Okay, now I know this is not worrisome. Now there is another case for all of you. This is a very interesting case. Maybe all of you can participate here. Maybe one of the second year. Who is the senior resident here? Second, third, fourth?
Sir, we, Swati,
Swati, which year are you?
final year's exam.
Oh, exam going. Very good. This is for you then. Just describe this lesion. What do you think about this? I don't want to scare you. If you're uncomfortable, just say I don't want to participate in this. So that's fine also. So don't get scared. Don't get worried. Don't become nervous. This is just to brainstorm all of us together and make it a little interesting rather than me just talking. So Swati, do you want to say something about this lesion? If you face this slide in the mic in your examination, what would you do? Like this is a 58-year-old female. She had a mass lesion. Ultrasound guided biopsy is done here, and you get this under your microscope. What do you see here, Swati?
So it's a single core of breast tissue
Yeah.
showing areas of collagenization
Mm-hmm.
with compressed ductal elements
Mm-hmm.
that are compressed on one side. I can't see the lining, but most of them are showing bimodal population and
Mm-hmm.
so bluish areas like mucin maybe extracellular on the bottom and yes, sir. And sir, can I go to high power?
Yeah, I'll take you. You just missed this area. There is a blood here. Did you see this?
Yes, sir.
There's
Extra.
hemorrhage, and then there's this sclerosing stroma here, and the cells. There are some single strands also, like here. Some are having glandular architecture, but some of the cells are streaming. You see that?
Yes, sir. Yes, sir.
Here, the cells are streaming.
Yes, sir. Cells are single line, single five pattern also, and
Yeah,
some.
it is like a sort of like a infiltrating pattern type of architecture. Can you see that?
Yes, sir.
Yeah, now I'll take you high power. The reason I want to show you at low power is that it's very important we capture all the features under low power. If we miss anything under low power, the high power will give you wrong impression. So in your exam slide also, like might be all benign looking, but then just a scan everywhere. Sometimes your slide might have more than, if it is a small biopsy, like say gastric biopsy or colon biopsy, or liver core biopsy, and these biopsies are usually in the fragments. So what I usually do is that I scan the entire slide and make sure I don't miss anything. And the low power is very, very important for all of us. If we miss at low power, then everything is will be wrong. So I wanted to highlight this area also. There's a hemorrhage here, and there is significance to it. So we'll talk about it. But as you rightly said, there is some mucinous degeneration, and then some at low power, the nuclei doesn't look bad actually, right? There are a lot of benign, like sort of a low-grade nuclei, but we'll go high power now.
It's sclerosing
So
adenosis.
now I can see that this is the high power, and go ahead, Swati. Now this is for you. Take it.
So, so some these are few. The cells are looking slightly atypical. Few
Uh-huh.
glands are here with myepithelial cells and the ductal epithelial cells. Few singly scattered cells also there, and mm,
What do you think about these single cells floating in between?
so they are showing mild
Hmm?
eumorphism. They are looking like that their nuclear, that myepithelial one. So the intervening cells are like myopithelial cells. They are slender cells.
Hmm?
Mm.
So what is your differential diagnosis here?
Sclerosing adenosis.
Hmm?
Uh, so usual ductal hyperplasia, means atypical ductal hyperplasia.
Oh, no, 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 no. So you see now, I don't see any, I don't know where you are going, but here my differential will be between invasive ductal carcinoma because of this single file pattern, and sometimes low-grade invasive ductal carcinoma can have similar look actually. And here you can see that there's a duct here, which is like a tubular carcinoma, has a similar appearance. Or my second differential diagnosis will be whether this is really uh, invasive background of desmoplastic stroma or the sclerotic stroma. What do you think about this background?
Neurosis.
What is the background here looking like? Have you heard about desmoplastic stroma or have you heard about the sclerotic stroma? Two things we notice when we look at the slide. One is the structure, the glands itself, and then another is background. Background helps us in pathology a lot. If we know what type of background is associated with, people are known by the company they keep, right? Have you heard that saying? Right? So, company of the cells, so what sort of company are they keeping here? So the stroma at the back is more of a sclerotic stroma. Now, what does a sclerotic stroma mean? There are two types of stroma. One is a desmoplastic stroma and one is sclerotic stroma. Now, desmoplastic stroma is produced when malignant cells invade the stroma, or when malignant glands invade the stroma, they release cytokines. And those cytokines attract fibroblasts. And those fibroblasts, they result in the proliferation of fibroblasts. So cytokines result in proliferation of fibroblasts, resulting in a desmoplastic stroma. So here we don't see too many fibroblasts here actually. All we are seeing is the pink homogeneous substance, which is a sclerosis here. And I can see some cells infiltrating in between. So my differential is here, is this some sort of a sclerosis happening in the background of a benign lesion, or it is an invasive cancer in the sclerotic background? Right? So this is, I'm not going to any definitive diagnosis at this time here. I am just going with the overall pathological diagnosis, like a pathogenesis of the whole lesion, that what is this lesion giving me the impression, So my differential is between benign and malignant now here. So what would you do to differentiate between the benign and malignant lesion?
So markers we put for myepithelial cells.
Myepithelial cell staining, right? So which stain would you use again? CK56, smooth muscle myosin heavy chain. And here is the smooth muscle myosin heavy chain. What do you see here?
So they are proliferating in the stroma.
Yeah.
Proliferating in the stroma.
So there's nothing proliferating in the stroma as such. So one thing is the diagnosis, second is the pathogenesis. If we understand the pathogenesis of the disease, then diagnosis becomes easy actually. So we want to be a clinician rather than a person who just interprets the slides. So here what is happening is that, let me go back now. I want to show you the slide from the beginning now. So we are going back to the first here, and you see that the same lesion having this sclerotic stroma, right? And then this is the hemorrhage here, right? Now, this patient had a mass lesion inside the duct, and you can see that there is a cavity type of thing here, right? Now, this was an ultrasound guided biopsy of intraductal mass lesion. What happens is that when intraductal papilloma undergoes torsion means it twists around itself, then it results in this hemorrhage. And this is what gives the milky discharge becoming browny discharge, because of the torsion of the stalk of the papilla. And then there is when it is a torsion, there is ischemia. Ischemia means no blood supply to that part of the tissue. So when it becomes ischemic because of the torsion of the papilla, the stroma becomes dead and sclerotic. Huh? And those cells which gets trapped, these are the cells which are the glands or ductal epithelial cells which are trapped in that torsed or the stroma which has undergone torsion. So those benign ductal epithelial cells are entrapped in the sclerotic stroma. So it can give like an infiltrating appearance. A low-grade ductal, invasive ductal carcinoma can have the similar appearance. So even though I might have like 30 years of experience in diagnosis of breast lesions, I will still do immunohistochemistry. I do not want to miss the diagnosis because even sometimes invasive ductal carcinoma can have sclerotic background because of infarction associated with it, right? So here you can see that those benign ductal and benign myoepithelial cells which are entrapped. There is no proliferation here. Okay, somebody used the word proliferation. There is no proliferation here. These are the benign myoepithelial cells which are entrapped in the duct which is undergoing a torsion and ischemic changes, right? And with the sclerosis here. So first there is a papilloma, then there is a torsion, then there is a hemorrhage, and then there is a ischemia followed by sclerosis. So that results in this appearance. Any questions on this? Yeah. So this case is good enough for you to pass or fail the exam, right? If you because this is like a case which will diagnosis is from benign to malignant, and sometimes coming to the diagnosis is not important in the examination. You may be wrong in your diagnosis, but if your approach is correct, like say if I didn't provide you this H&E slide, and if you say that this is an invasive ductal carcinoma, and you give all the justification of pathogenesis, how to differentiate between benign lesion and malignant lesion, even with the wrong diagnosis, you can pass the examination. But if you have a correct diagnosis, but you don't understand what's happening in this patient or what is the pathogenesis there, then diagnosis, computer can also give a diagnosis nowadays. But what differentiates us from a computer is to understand the disease process behind it. And that is why it is important to have the approach to the case rather than going towards the diagnosis. Does that help?
Yes, sir.
Yeah. So with that, I think it's 11:20 here. What is the time there?
So it's 10 minutes to 9.
Yeah. We started at what time, sir?
8 o'clock.
8 o'clock. So should we pause here and then we can meet next time? Is it okay?
That depends on tomorrow.
Yeah, we can meet again if that is okay, because I was planning to have 45-minute session, and then we can again discuss more cases as the time goes, and have too many cases, but again we want to go slowly and steadily. So 45 minutes, 1 hour is good timing for any educational process. After 1 hour, our brain becomes static, you know. So
really, thank you, sir, for the time and really very beautiful illustrations and cases.
thank you, sir. Thank you. It's wonderful. Maybe we can meet every 2 weeks, every 3 weeks, or whenever you are available, whenever I am available. And even like we can plan this session. It's nice to see everybody together. So
Yes.
wonderful. I see Dongre sir standing behind. Is that right?
Yes, Dongre sir is there. Ambedkar sir is there.
I thank you. Thank you. Nice to see you, sir. Nice to see you. Yeah, everybody, please stay safe. And I know it might be late in India, 9 o'clock, so you might want to take some rest. And I'm sorry to keep you late in the lab there.
our pleasure, sir. सर एक 2 ते 3 आठवड्यात भेटत जाऊयात. That's
हो
fine.
हो सर, तुम्ही मला सांगा की स्केड्यूल तुम्ही बनवून ठेवा आणि you just tell me that this is the schedule, then I will work around my schedule also, and we will work on it. Maybe every 2 weeks we can meet, or 3 weeks we can meet. And again,
For us, not an issue. Your time is important. 2 weeks, if you say, it is fine for us.
yeah, we can meet every 2 weeks. That's not a problem. Yes.
What we'll do, sir, we'll go by organ. Now we'll cover all lesions of breast.
We will go continuously. We will cover one lesion, one, two top cases at a time, and we just try to have approach towards the case rather than.
What we'll do is, let us say, coming 2 months, we'll all be discussing the breast lesions.
Yeah. We'll try to be. Sometimes I get some interesting case from Pravara or some my case. I'll discuss those cases also, and we'll keep on meeting.
आणि सर दुसरं याला अजून काही तुम्हाला वाटलं काही तुमचं हे ऑन्कोपॅथचं कधी सुरू होतंय सर?
1 ऑक्टोबर पासून प्रत्येक महिन्याला पहिल्या गुरुवारी तुम्हाला लिंक पाठवतो मी सर. तुम्ही सगळ्यांना फॉरवर्ड करा. That will be starting from 1st of October. You can have timing is just a second. Let me tell you. So 12 o'clock in Canada afternoon. So which will be like I think 9:30 or so in India.
Fine. No issues for us.
Yeah, 9:30 India time. Yeah, but everybody can see from their home. Everybody register online, and then you'll get a link in your email, and just click the browser, and all the international faculty members who have visited Loni in past. Dr. Jagmohan Sidhu, Dr. Vijay Joshi, Dr. Megha, Dr. Bharat Nathwani, all those will be presenting different topics. It's free of cost, and you will get recording also in your email after the presentation is done. So you can save the recordings also and review them at a later date also. It's a wonderful opportunity.
Yes, sir. So that would be very nice. So we go along with now, let us say, 2 weekly schedule.
Yeah.
Plus that activity.
Yes, sir.
Thank you for the time.
Thank you, sir.
Now we got 5 more new postgraduate students.
Oh, congratulations.
Number is now increasing.
That's very nice. Yeah.
For they are interacting with you for the first time.
Yes. No, it's wonderful. We can keep on meeting. This is a good platform, and we can, if you have any questions, we can talk while we are talking on the cases.
Fine.
Maybe next time when we meet, maybe you can have a better microphone or something.
Yes.
Something like which goes around your head, and which only one person also can speak through the microphone.
Right.
So the sound is clear then.
Right, sir.
Yeah. Thank you, sir. Thank you.
Yes, sir. Thank you very much.
Thank you. Bye. Good night, everybody. Bye. Good night.
Sir, 1 minute फक्त एक snap घेऊयात.
Yes, sir.
With this screen, we'll take a photo. So we'll just try to get in.
Yes. Oh, namaskar. Nice.
मेरे पीछे कौन है उसको खड़ा रहना पड़ेगा. इसके आगे डोंगरे सर के पास जाओ रोता. खांगरकर से तुम तो फोन खाली गया तुम चेहरा दिखा.
Very nice.
Yes, sir. Thank you, sir.
Thank you, sir. It's a recording झालेला आहे, so I will send you the recording of this meeting.
Okay, sir.
So you can archive this recording, and if students want to review them, they can review them again next time when we meet.
आपण घेतला सर ब्रेस्ट म्हणजे then सगळ्या lesions cover होते.
Oh, I have a lot of collections of cases. So what we'll do is that we'll talk about variety of cases every time when we meet. Basically, one thing is covering the cases. Second thing is understanding the basics and approach. Basically, that is what we want to learn from each other. How do we approach a case?
That is most important.
Once you have approach, you can do anything. You can build on it.
Right, sir.
Yeah.
Okay, sir.
Okay. Good night, everybody. Take care. Bye.